A normal individual, when he takes in gluten containing foods, for example wheat, this wheat within the GIT tract is broken down into gluten, which is absorbed into the small intestine through enterocytes that line the villi. These enterocytes have an enzyme specially devoted to the degradation of gluten further. This is known as tissue transglutaminase. But in people with celiac disease, this gluten, which is harmless, activates T helper cells, and these T helper cells then activate B cells and cytotoxic T cells. Cytotoxic T cells directly attack enterocytes, whereas B cells form IgA antibodies. These are normally for the mucosal surfaces throughout the body to protect them. But here abnormal IgA are formed against three things: gliadin, the subunit present in gluten, tissue transglutaminase enzyme that is for the digestion and breakdown of gluten, and endomysium, a protein that covers the smooth muscle fibers, and here the smooth muscle fibers of GIT tract. Not only this, but these IgA are dispersed through blood and deposit in the skin. In the skin, they cause inflammation and lead to dermatitis herpetiformis. Our small intestines have finger-like projections known as villi. These villi help to increase the surface area of the small intestine so that maximum absorption can take place. In celiac disease, these are villi. Each villus is lined by tiny small enterocytes. In celiac disease, when the person takes in gluten containing food and it is broken to gliadin and the gliadin gets into the enterocytes, the anti-transglutaminase and anti-gliadin antibodies attack these enterocytes, and so it causes destruction of the villi, and villi become blunt, causing an extreme reduction in the surface area for absorption, and so malabsorption occurs. We have HLA genes in our DNA. These HLA form MHC proteins. HLA have different alleles. In individual with HLA DQ2 and HLA DQ8 alleles, they are more prone to celiac disease. These HLA genes form MHC proteins. MHC proteins are present on all WBCs in our body. When a WBC takes in any bacteria or pathogen, it breaks down into proteins and sends it to the other cells of the body. In celiac disease, the HLA alleles form MHC proteins that, instead of presenting the harmful antigens and microbe parts to other cells, it causes the harmless gluten to be presented as a foreign antigen. In this way, antigen presenting cells activate the T helper cells, and it ultimately leads to villi destruction. There are other diseases that are also linked to HLA. HLA-linked autoimmune diseases may occur along with celiac disease and include type 1 diabetes mellitus, Hashimoto thyroiditis, IgA deficiency, primary biliary cirrhosis, and myasthenia gravis. There is a mnemonic to learn these names. The ceiling of DHA is even liked by the Prime Minister. Patient of celiac disease is a young adult, even a child and infant. You will have chronic diarrhea, abdominal distension, and signs and symptoms of malabsorption, including weight loss, nutrient and vitamin deficiencies. Iron deficiency will cause microcytic anemia by folate deficiency, and osteoporosis due to vitamin D and so calcium deficiency. Apart from these, if the patient is child, he'll have short stature, delay in growth, as well as pubertal delay. If the Patient is an infant, he'll start symptoms when mother puts him on weaning. And in case of child, growth delay, puberty delay, and short stature will be imminent. To investigate celiac disease, we use endoscope to take biopsy specimens either from duodenum or proximal jejunum. The biopsy specimen will not only show the blunting of villi, but it will also indicate signs of inflammation, which is the presence of lymphocyte within the epithelium, and within the crypts between the villi there is cellular hyperplasia. Serology can be done that involves IgE detection, and 3 types of antibodies can be found in the blood of patient with celiac disease. A skin biopsy helps through immunofluorescence to indicate the IgE deposition in the skin if there is skin infestation. The IgE are deposited where the epidermis meets with the dermis at the area of dermal patella. D-xylose test is also done, and the patient is given a xylose solution, which is a simple pentose sugar. It does not need any enzyme and it is simply absorbed in the small intestine. But in patient with celiac disease, his absorptive area is less, and therefore when we take blood sample after ingestion, his blood levels of xylose are low. It helps differentiates chronic pancreatitis, which also has steatorrhea, just like celiac disease. But in chronic pancreatitis, there are no enzymes. Xylose does not need any enzyme, therefore blood levels in chronic pancreatitis of xylose are high, where it is not in celiac. To treat the patient, we simply put him on gluten-free diet, and we highlight all the foods that contain gluten and tell him to refrain from it. In many patients, even the blunting of villi gets reversed after gluten-free diet. Along with it, we correct his deficiencies, give him iron, folate for anemia, and calcium and vitamin D for osteoporosis. If the patient does not respond to these things, then we proceed towards use of steroids, corticosteroids, and immunosuppressants. This suppresses the immune response and the autoantibody formation against gluten. For skin lesions which are pruritic vesiculopapular lesions, we give him Depson. A related scenario, 28 years old gentleman presents with loose stools and weight loss for a month. He does not have any fever, abdominal pain, vomiting, or blood in stool. He also developed pruritic lesions on upper limbs 1 month ago. He is pale emaciated with bilateral pedal edema. His HB is 7, WBC 7500, albumin is also low, and PFTs are normal. His chronic diarrhea and weight loss and his young age, these indicate towards celiac disease. The diarrhea in celiac is in some cases described as offensive, bulky, and sticky stool. Here the patient has dermatitis herpetiformis and is also pale with low HB, which means he's anemic. He has bilateral pedal edema, which is due to decreased protein absorption, and this reduction has led to hypoalbuminemia that is indicated as edema. His WBCs are normal, which shows that it is not gastroenteritis, means any kind of food poisoning, and his TFTs are normal. When the patient has hyperthyroidism, he also has diarrhea, so they have excluded it here. So all the main symptoms, chronic diarrhea, weight loss, skin lesions, and edema, along with anemia, all these show that the patient is suffering from celiac disease.